Assalamu alaikum everyone. Today's video is a continuation of my previous lecture on acute coronary syndrome. In this video, we will discuss the management of acute coronary syndrome. So let's start with the analgesia. It is important to relieve the pain and relieve the anxiety of the patient regarding the death. It reduces the adrenergic drive, so reduces the blood pressure and ultimately decreases the size of infarction. Analgesia includes IV morphine 5 to 10 mg and also give the patient antiemetic because the emesis or vomiting is common in these patients. So antiemetic metoclopramide 10 mg should be given through the IV route. Doctors usually prefer the IV route because through the intramuscular route, the skeletal muscle has less blood supply during the attack of or less perfusion during the attack of myocardial infarction because of decreased cardiac output. The other agents include antithrombotic therapy, which includes antiplatelet drugs and anticoagulation drugs. The most important drug in the antiplatelet therapy is aspirin. Aspirin should be given 300 mg single oral dose and then followed by 75 mg daily. It inhibits the cyclooxygenase pathway and ultimately reduces the platelet aggregation. The other options are ADP receptor blockers. These includes clopidogrel, and the dose for clopidogrel is 300 mg through oral route and then followed by 75 mg daily. Ticagrelor, this is basically also a ADP receptor blocker and it is more potent and it has more efficacy as compared to clopidogrel, but the most common side effect of ticagrelor is dyspnea or difficulty in breathing. The dose for the ticagrelor is 180 mg once and then followed by 90 mg daily. Prasugrel is basically a ADP receptor blocker. It is used during the percutaneous intervention along with the other antiplatelet agents. Glycoprotein 2B or 3A inhibitors. These includes apixaban and tirofiban, and it inhibits the platelet aggregation and thrombus formation. So these are basically used prior to the percutaneous intervention along with the other antiplatelet drugs. Now come to the anticoagulation therapy. It includes unfractioned heparin and enoxaparin. Enoxaparin is basically low molecular weight heparin and fondaparinux. This is indirect inhibitor of factor 10A and it has more potency and more efficacy as compared to other forms of anticoagulation therapy. And bivalirudin or dacirutin, this is basically direct thrombin inhibitor. All these drugs inhibits the thrombus formation and inhibits the reinfarction in these patients. It should be continued for 8 days or until the discharge of the patient from the hospital or until the coronary revascularization occurs. Basically, the anticoagulation therapy is important in the non-STEMI or unstable angina. It is not used in the ST elevation MI. Now come to the antianginal drugs. The antianginal drugs includes nitrates and beta blockers. The nitrates is basically commonly used is sublingual triglyceryl nitrate 300 to 500 mg microgram. It reduces the preload because it is a vasodilator, reduces the preload and reduces the afterload, so decreases the workload on the heart and decreases the oxygen demand. But the side effects are hypotension and headache, orthostatic hypotension and syncope plus headache. Now come to the beta blockers. Beta blockers are integral part of the basically MI, post MI, and they used in the long term management of or the late management of myocardial infarction. These includes metoprolol, carvedilol, and other some drugs. The contraindications, these drugs basically reduces the heart rate and reduces the contractility, so reduces the myocardial demand for the oxygen. And the contraindications are if the patient has pulmonary edema and bronchospasm, especially in the asthmatic patients, because these drugs, beta blockers, especially the non-selective beta blockers, exaggerate the asthma because these drugs causes bronchospasm or bronchoconstriction. So these are avoided. These should be avoided in bradycardia, hypotension, and bronchospasm. Now come to the reperfusion technique, prevention and fibrinolysis or thrombolytics. This reperfusion techniques has no role in the non-ST elevation MI or unstable angina, but these are reperfusion techniques are very important in the management of ST elevation MI. Let's talk about the percutaneous intervention, in which catheter is inserted through the skin into the femoral artery and indirectly reaches the coronary arteries, which are basically obstructed, and then balloon is inflated or deflated, and then finally stent is placed to relieve the obstruction. And this basically stunt contains the thrombolytic agents. It is usually performed within the 90 minutes. So door to balloon time is under 90 minutes. It is basically a treatment of choice in the patients of ST elevation MI, and it reduces the risk of death and also reduces the risk of recurrent myocardial infarction and stroke in these patients. If the facility of the percutaneous intervention is not available in the hospital, then the next treatment option is fibrinolysis or thrombolysis. It is basically benefit is greatest within the 2 hours, and ideal time is under 30 minutes for the fibrinolysis or thrombolytic agents. The thrombolytic agents includes altiplase, retiplase and tenecteplase. These are basically tissue plasminogen activators, and especially the altiplase is the agent of choice in these patients, and the other options are streptokinase. The indication for fibrinolysis or thrombolysis is basically ST elevation MI. These reperfusion techniques has no role in non-STEMI or in the unstable angina. There are some contraindications for thrombolysis if the patient has stroke, ischemic stroke or hemorrhagic stroke, and has CNS neoplasm, or there is active bleeding in the body, and there is aortic dissection. So these are various contraindications for thrombolysis. Let's summarize the management of acute coronary syndrome in the emergency department. If you are suspecting that the patient has acute coronary syndrome by the features, then first attach the cardiac monitor and then IV assess, that is cannula should be inserted, and connect the oxygen mask immediately by starting 2 to 4 liters of oxygen. Through the oral route, aspirin 300 mg and clopidogrel 300 mg should be given, and through the cannula, antiemetic like metoclopramide 10 mg and IV morphine 5 to 10 mg should be given. Through the sublingual route, glyceryl trinitrate should be given 300 to 500 microgram through the sublingual route, and then perform the 12 lead ECG, and cardiac enzyme should be checked, and then call the cardiologist. If there is ST segment elevation and enzymes are elevated, that is patient has ST elevation MI, then cardiologist will perform the percutaneous intervention, and then also if this facility is not available, then thrombolytic agents should be given. And after the 12 lead ECG and cardiac enzyme, if there is ST segment depression and cardiac enzymes are elevated, it means that patient has non-ST elevation MI, but ST depression along with normal cardiac enzyme, it means that patient has unstable angina. Then the other options include low molecular weight heparin along with or without glycoprotein 2b3 inhibitors, that is apixaban or tyrofibane. So this was basically the emergency management of acute coronary syndrome. This was a summary of whole management. Now come to the late management acute coronary syndrome, which includes the lifestyle modifications like weight reduction, cessation of smoking, regular exercise, cessation of alcohol, and dietary modifications. The secondary prevention drugs that prevents the reinfarction includes antiplatelet therapy, which includes aspirin and clopidogrel combination after the myocardial infarction. It should be used at least for 3 months. Beta blockers like carvedilol and metoprolol, nitrates like trinitroglycerine, and statins like atorvastatin and simvastatin 80 mg should be given, because these drugs basically makes the plaque more stable and inhibits the reinfarction in these patients. ACE inhibitors includes captopril or enalapril. These ACE inhibitors are important because after the MI there are more chances of cardiac failure. So these ACE inhibitors are used to prevent the cardiac failure. Rehabilitation therapy includes ICD, that is implantable cardiac defibrillator. These are helpful in prevent the sudden cardiac death. These are basically defibrillators which are placed within the myocardium of the ventricles, and these picks up the irregular heartbeat and prevents the sudden cardiac death in these patients, especially in the patients whose the ejection fraction is below 35%. So the ICD should be implanted in these patients. So this is all about the management of acute coronary syndrome. Thank you so much for watching this video.